Hello, everybody, and thank you for attending this seminar. Sorry for the delay in sending you the recorded slides before. As you can see, today we'll be talking about Candida and endemic fungi. The Candida is really a very widely distributed fungi. We have several species that are commensal and colonize our skin and mucous membranes of humans. 30% of humans are colonized with Candida albicans at any given time. In critically ill or immunocompromised individuals are more prone to develop both superficial and life-threatening invasive Candida infections. This is why it is a leading invasive fungal infection globally and responsible for 8 to 10% of nosocomial bloodstream infections. It is a worldwide organism, most common fungi encountered to affect humans. It's rarely a lab contaminant whenever isolated. It's present as a normal commensal flora on our skin, in our GI tract, in sputum if once isolated, in female genitalia, and in urine in people who have Foley catheter. The infection is vastly endogenous, it's rarely exogenous, so we usually acquire our own Candida in systemic infections. Human-to-human transmission is rare and occasional. However, nosocomial acquisition from one patient to another is not very common, but now it's gaining more and more significant. Candida is a yeast. It's a unicellular. It has a thin wall and reproduce by budding. To grow well in routine blood culture bottles and in any media, especially if it's a special fungal media, mainly Saburo. Improved recovery from blood cultures or body fluid, because now we're using the automated systems, and this is why we have appreciate the importance of Candida more and more in modern times. In clinical specimens, it looks like a yeast, and it has a pseudohyphae, and sometimes these pseudohyphae are so elongated that they appear like hyphae. On culture plate, it looks like a smooth white glistering colony, resembles those of Staphylococci but much larger. And the microbiology of Candida, it reproduces by budding, but it is unable to develop ascospores or multiply sexually, so this is why it's classified as fungi imperfecti. It can produce germ tube, mainly those Candida albicans and Candida dubulensis, and not by other Candida species. And remember this from now, this is very important because the reproduction of germ tube can identify Candida albicans versus other species, which carries an important clinical significance in real practice. The phenotypic method to identify Candida can depend on several modality: the rice agar, the birdseed agar, the saborodextrose, which we use quite often, the chromo agar Candida, the AP, and the carbohydrate assimilation assay, the API identification, and finally the VITAC, which quite also we use also at AUB. The culture, it can grow overnight in most cases. There is an ability to do molecular sequence analysis to identify the isolate, and this is really very highly accurate. The best way to appreciate the Candida is really through laboratory physiological testing, and the most important rapid way to identify albicans versus non-albicans, because of this clinical significance of that, is usually through the germ tube method. A gram stain, a Candida can stain by gram stain and by fungal stain, so it's an easy organism to identify. This is what I'm talking to you about. It's called the parent yeast cell. They are budding yeast, and when they bud, they get elongated and they produce pseudohyphae. This is what I'm referring to as the germ tube method, which is mainly a function of the Candida albicans and the rarely encountered Candida dubulensis. These are the chlamydospores in A, and these are the pseudohyphae in B. So for a non-expert eye, they may appear as a hyphae, and this is the budding yeast what you see when the yeast starts budding or increasing. These are the blastospores, and they are elongated, producing a germ tube method. So once you see this in a lab, you will know that you are dealing with Candida albicans. This is another way of showing the germ tube production. And this is a direct smear of urine from a patient with Candida albicans infection, and you can see here, you can see, if you look at it, you will find the yeast form, the pseudo-hyphal form, and the hyphal form. So this is one, so you can see if you have, for example, in your test a question in a pathological specimen or in a microbiological specimen, you could really detect the yeast and the hyphae will form together in one infection. Then you should start thinking along the possibility of Candida infection. This is what Candida albicans look on a blood agar plate. For those of you who have attended the microbiology laboratory session, it can easily be missed with a staphylococcal colonies. This is the Candida albicans on a saboro-dextrose agar medium. You can see they look like waxy, smooth, shiny colonies. They are very typical of Candida. And this is the use of other methods to identify Candida. And you can see here we're using the morphological study, and we can use also the chemical identification method. And you can see this is where the Candida was cultured, and it was put on several reactions here, and it is, as you can see, it's urease negative, which will probably suggest that it is a Candida. So we know that there are around 200 species in the genus Candida. 20 have been incriminated in a human pathogen, and the list may even get larger and larger. And the most recent addition is the Candida auris, which is probably one of the most aggressive Candida species we have encountered. It is resistant to several antifungal agents, and it is one that can be transmitted from one person to another. So if you got a question in your exam, what Candida deserves isolation, practice if you have a patient with Candida infection, which one will deserve isolation, you would assume that the right answer will be those affected by Candida auris. So the clinically significant Candida are mainly albicans, glabrata, parapsilosis, tropicalis, cruzii, and auris. And we know that there are parapsilosis, there are many other Candida that have been incriminated in human disease. If you look at this old slide, if we were probably giving this presentation many years ago, we would assume that the vast majority of Candida infection are albicans in nature, but because of the changing epidemiology of Candida, now we are encountering more and more non-albicans, and you can see albicans is losing their prevalence. In the past, we used to believe they represent 80 or 90%. Now we believe they represent 50 or less. Even in some medical centers in the West, they represent less than 40%. So this is data from AUB, where we can see that we have albicans and non-albicans together. And if you look at the non-albicans, we will find that we have a lot of glabrata, tropicalis, cruzii, kfir, parapsilosis, pelliculosa, and some of them were non-speciated. However, we haven't really encountered auris so far at AUB, and we are lucky for that. How the distribution of Candida species is affected by the use of antifungal agent, and mainly in prophylaxis and the duration of prophylaxis. And if you follow with me here, you will find that if there is no antifungal prophylaxis, then the most important Candida encountered will be always albicans. If you use antifungal prophylaxis for a brief period of time, it remains to be albicans. If you use it for a prolonged period of time, you will find that albicans will lose its significance, and we are encountering more and more non-albicans. And if you look, depending upon what are you using for prophylaxis, if you're using a simple azole like fluconazole, then you are going to affect the ecology of the candida, and you will start losing more and more the prevalence of Candida albicans. If you're using echinocandins such as caspofungin, then probably you'll even lose albicans more and more. This is important because we know that non-albicans are usually more resistant to treatment than albicans. This brings us to the topic which is called the multi-drug resistant Candida. The MDR Candida is relatively a new term. Its widespread use or misuse of echinocandins mainly and other antifungal agents have led to that. Non-Candida albicans MDR species are encountered more and more. Candida glabrata heads that list with FKS mutant echinocandin resistant, and Candida auris, which is one that have special guidelines for management and treatment and isolation practices. And recently the Candida guillermandi complex has been added to the list of multi-drug resistant. The body defense mechanism that fights Candida is very impressive. We know that we can defend against Candida by first of all our integument. So any interruption in our integument and our skin structure will lead to cutaneous candidiasis. This can be seen in wounds, in injuries, in burns, and in diabetic patient and in obese patient. We have the polymorphonuclear cells. They are very important because they can damage the pseudohyphae and are involved in phagocytosis of blastospores. This is why Candida is an important pathogen in febrile neutropenia in patients who have cancer and have no neutrophils because of the chemotherapy they have received. Monocytes and the eosinophil and macrophages, they ingest and kill Candida. Lymphocytes, they are responsible for cell-mediated immunity. So if you have a deficiency in your cell-mediated immunity, you're going to have chronic mucocutaneous candidiasis. This is very encountered commonly in HIV and AIDS patients. The humoral immunity, the antibody, they are important. IgG enhances polymorphonuclear function. The complement help in opsonizing of blastospores, so this will allow their later phagocytosis. And we know that serum iron binding protein and other factors can be also helpful. The natural killer cells, they contribute to the rapid innate immune response, and they are important in the antifungal activity. The host defenses involved in combating Candida. In animal studies, we have appreciated the importance of intact complement because the more we have complement deficiency, the more likely we are encountering severe and resistant mucocutaneous candidiasis. Neutrophils are important in both number and function, so febrile neutropenia or prolonged neutropenia is an important predisposing factor to acquire a Candida infection. Secretory and humoral immunoglobulin are important because these antibodies do not protect against invasive disease if other host defenses are sufficiently impaired. So they are helpful if you have a healthy host. If you don't have a healthy host, then immunoglobulins alone may not be very important. What about the human data? In T lymphocyte people who have low T lymphocyte function, mainly CD4, they can have severe esophageal and invasive candidiasis. Other forms of T lymphocyte impairment are implicated in chronic mucocutaneous candidiasis, and patients with neutrophilic dysfunction, mainly below 500 per ml, will lead to invasive bloodstream infection and invasive Candida infection. The antigenic structure of Candida is quite complex because Candida is a multi-layered cell wall, and it consists of this cell wall consists of glucans, chitin. They give the Candida mechanical strength and stability. the mannans and the mannanoprotein, and the proteins are important in eliciting and triggering the immune response. So this is why Candida pathogenesis is quite complex. In order Candida to produce an infection, there is what you call an a cascade of events is involved here. The Candida has to adhere initially, it has to colonize, then it has to invade. Carbohydrate or proteins on the epithelial cells facilitate adhesion of the yeast to human tissue. This is what we usually see in the oropharynx. Oropharyngeal candidiasis is very important. In the gastrointestinal tract, invasive candida esophagitis is very important, and the genitourinary tract, and so genitalial candida infection is also very important. So the attachment will be followed by replication to colonize the host. This is what we call the saprophytic relationship, where Candida and the host can live together without really any problem. A human colonized with Candida albicans in the GI tract occur during the first months of life. So colonization is acquired at early stages of life. The initial colonization is acquired from the mother by the vertical transmission, and if we have an impaired host immunity, then conversion of Candida from colonizer to an invader, mainly through the GI tract, is very important. So this is an important issue to remember. Most of the invasive candidiasis come from within, from our GI tract, from our own flora, and this is why we consider the Candida infection as an endogenous infection. We continue with the pathogenesis. The virulence factors of Candida are quite numerous. The adhesion property can be helped by the epithelial, can be helped to attach it to the epithelial surfaces, to the endothelial tissue, to the platelet fibrin clot, to plastic, to archaic, and to catheters. Why this is important? Because Candida can form a biofilm. So if it adheres on plastic, archaic, and catheters, it will cause a catheter. It will cause eclampsia, a catheter related bloodstream infection, and this is very serious, and it will be very difficult to treat. Rapid transformation from yeast to hyphae is important because, as we can see, we have seen in clinical specimen, we have seen the yeast and the hyphal form existing together. This morphogenesis will probably confuse the immune system. It will elicit several immune responses, and it is responsible for a lot of the inflammatory reaction that takes place during Candida invasion. The hydrolytic enzymes are usually present. They can hydrolyze tissues around the Candida. The Candida, in each form, whether it's a yeast form or a hyphae or a pseudohyphal form, will have certain antigenic variation. It can really produce mimic the host. It can really mimic the host, and this is where this mimicry is important because it can confuse the immune system and allow Candida to exist uninterrupted in our body system. So the Candida strategy to escape recognition and elimination by the host immune system are numerous. The beta-glucan shedding, as you can see here, the inhibition of phagolysosome formation, which occurs within the cell, the macrophage damage, and the hyphal overgrowth, as you can see here, because usually the macrophages are destroyed and the hyphae will grow uninterrupted. Modulation of the T cell response can occur here, and the phenotypic switching, as you can see, from the yeast to the pseudohyphae to the hyphal form, and then to the germ tube, which will all cause the confusion of the immune system. And finally, the AMP resistant mechanism, which is responsible for the efflux pump that will make the Candida be ejected from outside the phagocytic cell. Influence of the host microbiota and candida colonization and infection. This is a very important concept. We know that candida is favored in people who receive antibiotics. And why this is important? Because we know that candida can colonize our GI tract, and by colonizing our GI tract, candida will live there with the bacteria. If we give antibiotics, then we can affect the bacterial flora of the GI tract, and this will favor the candida to overgrowth, and the overgrowth may lead to local or even more invasive infection in susceptible hosts. What about the biofilm? Candida species are frequently found in normal microbiota of a human, facilitate encounter with most implanted biomaterial and host surfaces, rough, non-smooth surfaces. So any biomaterial you put it, or any catheter device, tube that you inserted, will allow candida biofilm formation that will overgrow there. It will form a calyx that it will prevent our immune system from attacking the candida. Candida albicans remains the fungal species most commonly associated with biofilm formation. However, the other candida species can do that. And now, since we are using more and more medical implant devices in people who are immunosuppressed, this will increase the possibility of candida infection, and this will lead to increase in what you call in the percentage and the prevalence of candida related bloodstream infection and catheter related bloodstream infection. It's now believed to be the third leading cause of catheter related infections. This is what I'm talking about. Imagine that candida, this is a candida albicans biofilm. You can see that neither antifungal agents nor our immunity will be able to attack such a complex calyx full of biofilms. How do biofilms usually form, whether be it bacterial or candida? They usually pick a rough surface or a prosthetic surface, be it metallic or biological surface, whatever. They are initially free floating. They start there, come to this disrupted surface or foreign surface. They start agglomerating. This agglomeration will end up building some sort of a colony, and this colony will start sealing itself, and you are going to form several colonies, and these several colonies will get larger until they burst, and they will go there to form another colony. And so this is how the biofilm will always be capable of feeding and increasing its size and itself. This is the laboratory equivalent of a Candida albicans biofilm formation. You can see this is the free-floating candida on a culture media. This is the disrupted culture media where they start conglomerating and gathering. This is when they start forming the biofilm. This is when the biofilm start becoming more complete. This is when it is usually erupted, and it is to go there again and to start forming another sequence of a new biofilm. So why biofilm are important? Because they contribute to resistance and to contribute to treatment failure. So the role of biofilm is important. The candida biofilm, they have very high burden of candida, so even if you are able to attack them, you will be very difficult to eradicate them. And the antifungal concentration inside biofilm is always much less than free floating or outside by the biofilm, and the clinical impact is usually resistant and the treatment failure. In Candida disease, the host-related factors which predispose a person to Candida infection are important. We have the endogenous factors which are related to the host himself, such as immunosuppression, irrespective of the cause of the immunosuppression, diabetes mellitus, especially uncontrolled diabetics, and extreme of ages, mainly those frail and elderly, or low birth weight neonates and very young people. The structural factors that will predisposed to candida infection are mainly those that are related to the break in the integrity of skin and or mucous membranes, such as in patients with burns, trauma and maceration, those who have multiple catheters in IV lines, central lines, Foley catheters, and foreign bodies. Abdominal surgery is very important because we know that Candida usually resides as part of the normal flora in our GI tract. So abdominal surgery is an important predisposing factor to severe candidiasis. And recently, necrotizing pancreatitis has been associated also with systemic candidiasis. The exogenous factors that usually the host in hosts that predispose to candida infection are mainly antibiotics, especially prolonged and broad spectrum antibiotics. Since antibiotics will kill the bacteria that will compete with the candida inside our GI tract. So, but the more you give antibiotic, the more they are broad spectrum and prolonged, the more likely that the candida will flourish in the GI tract, overgrow, and produce invasive disease. Prosthetic material and devices, and this is here comes the role of the ability of candida to produce biofilm and stick on catheters and prosthetic material and devices. And TPN, total parenteral nutrition, because this is usually given to people who have major surgery on their abdomen. They cannot take food, and it's usually given vis-a-vis central line. So these are all in themselves, in their own capacity, reasons for severe candida infection. The environmental factors are quite a few, including the intensive care unit. We know that patients in critical care areas are more at risk of developing candida. Nosocomial hospital-acquired infections also will predispose to candida infection, and of course, candida can contaminate food, water, or plant. Since it's very important to start treatment of candida as early as possible in a critically ill patient, so there is what we call the candida score in non-neutropenic critically ill patient. This score is based on certain factors that predispose to candida and the fact that the patient has what we call multiple sites of colonization. So if someone in an intensive care unit, for example, on broad spectrum antibiotic, has severe sepsis on receiving total parenteral nutrition and had surgery in an ICU admission, mainly intra-abdominal surgery, and we could really identify or isolate candida from either the sputum or from the urine itself. Although we know that candida does not cause pneumonia, yet we will consider it as a colonization site, and if you have more than one colonization site, then you are at the risk of having invasive candidiasis. The clinical syndromes caused by candida are numerous. We will start with the superficial ones. Oropharyngeal candidiasis, what we call the white thrush you see on tongue of people, especially those who have received recently antibiotics, glossitis, angular chelosis, perlici, chronic draining otitis externa, especially in diabetic patients. And this is an example of an oral thrush where we can see the white tongue. So this is probably, if you go back to the history of a similar patient, you will find that they probably have received a long course of antibiotics. This is the same oral thrush, but in a immunocompromised individual. This is an HIV/AIDS patient, and you can see the severity of the oral thrush here. And we know that in immunocompromised individual, it can extend to cause as well esophagitis. This is oropharyngeal candidiasis, severe as well, showing the thrush, the glossitis, the stomatitis, and angular cheilitis, as you can see here on the edges. This is typically also an immunocompromised or T-cell deficient patient. This is a nappy diaper rash in an infant patient spread to the mouth and area. So this is probably would worry because usually if you have candida so spread, then you would assume that there may be some sort of mucocutaneous disease and T-cell dysfunction as well. The cutaneous candidiasis can occur in normal or immunosuppressed individual. Risk factors are the same risk factors for the candida, diabetes, burn, and radiation that will affect the integrity of the skin and the integument. Usually, it causes folliculitis-like illness and onychomycosis, which is the infection of the bed of the nail. Diagnosis is usually clinical, and if you want to do some microbiological diagnosis, we can take some scrapings and do a KOH smear, potassium hydroxide smear. Chronic mucocutaneous candidiasis usually occurs in immunocompromised individual and mainly those who have T-cell abnormalities. The infancy, it occurs also in infancy and childhood because those people that usually in infancy they have also some low-grade cell-mediated immune deficiency. In this slide, we can see severe onychomycosis in an immunocompromised HIV patient. As you can see, usually many people, including probably some of you, may have onychomycosis, but this is a severe form which reflects cell-mediated, T-cell mediated deficiency. The oral and esophageal candidiasis can result from antibiotics or can happen in a cancer patient on chemotherapy, in an HIV patient, or on patients who are receiving immunosuppressive treatment. The diagnosis is clinical. We do KOH smear on scraping, and if we suspect esophagitis, we need to do endoscopy to document the involvement of the esophagus. The treatment is usually topical versus systemic. If it's oral, then it is probably topical will be enough. If it's systemic or severe, if it's esophagitis or severe, then we need systemic therapy. Vulvovaginal candidiasis can occur in normal as well as in immunocompromised individuals. The predisposing factors could be diabetes, could be pregnancy, could be a prolonged course of antibiotics in a lady. They usually produce itching and discharge, mainly whitish to yellowish discharge from the vagina, and the diagnosis is symptomatology plus always doing some microbiology and KOH smear. This is a picture of a very severe mucocutaneous candidiasis, and this is also a slide showing severe penile candidiasis. This is neonatal congenital candidiasis. This is the same picture of the same person, baby here. This tells you that this is disseminated disease, and you would start worrying about a T-cell function deficiency. Deep-seated candida infections usually can occur in any part of the body, and cutaneous and subcutaneous infection can occur in the cutaneous membrane or the skin or any part of the integument. You can see, candida, blood candidemia or bloodstream infection is also another point to worry about. You can see we can have abscesses in the spleen, in the liver, in the lung, although we don't have pneumonia, but we can have an abscess. We can have endocarditis, and we can have, name it, we can have it even a brain abscess. So any part of the body could be affected by deep-seated candida infection, while superficial infections, be it in the hair, nail, or skin, we have described them before, or cutaneous or even subcutaneous infection. Invasive candidiasis includes two closely related and often confusing conditions. We have candidemia alone, and we have non-candidemia systemic candidiasis. They occur mainly in immunocompromised individuals or in those who are critically ill, prolonged stay in ICU with other predisposing factors. In an immunocompromised individual, neutropenia is an important predisposing factor. Mucosal injury is another important factor due to chemotherapy, where you will see a lot of mucositis, and selective pressure of antibiotics. So you have an immunocompromised neutropenic patient receiving antibiotics and has mucositis because of the chemotherapy. In a critically ill patient, in an ICU patient, the more risk factors you have and the more the colonization index turn out to be positive in sputum or in urine, then this patient is predisposed to invasive candida infection. Meanwhile, candidemia, the most important source of candidemia is a central venous catheter infection, and other risk factors including hospital stay, intravenous drug use, and of course cancer, burn, patient post-surgery, mainly abdominal surgery, organ transplant, immunosuppressive treatment, TPN, and antibiotic. It carries really a high rate of attributed mortality, somewhere around 38% or 40%. The marker for dissemination and invasive disease usually is important, and it can really seed anywhere in the body. Febrile neutropenia is one entity where you suspect and treat as if it is candidemia. You have somebody who is febrile, has very low neutrophils below 500, received chemotherapy, has been on antibiotics for at least 5 to 7 days, and you don't have a focus, then you would really consider that this patient may have an invasive fungal infection, including a candida infection. Mortality from candidemia could be really very high, and the mortality can be even higher when you have a higher Apache score, and can reach up to between 60 and 80%. And those people who have high Apache score may be a poor responders to antifungal therapy. This is what I'm talking about, the eye involvement, the retina. So anybody who has candidemia should really be evaluated for deep-seated infection with a fundoscopic exam. So please remember that whenever you have candidemia, then a fundoscopic exam should be done to this patient to rule out endophthalmitis and this involvement of the eye. This is how Candida appears in the blood. You can see a cluster of gram-positive large cocci. They can miss them for a staph aureus, but they are much larger than staph. And here you can see the skin manifestations of candidemia. So this is so whenever you have also a bloodstream infection with candida, you check the eye fundoscopy and you check the skin to make sure, look for these lesions that are usually evidence of invasive disease from candida. Other site of candida infection can be anywhere. We have talked about that, including of course the bone and the joint and the osteomyelitis and the sciatica. And the treatment of candida, I'm not going to elaborate much on that because we know that the treatment depends upon whether this is superficial, cutaneous, or severe, and it depends upon the host himself, whether the host is an immunosuppressed individual and has a lot of risk factors, or whether he is an otherwise or she is an otherwise an immunocompetent host. And of course, it depends upon the epidemiology, because as we said before in this presentation, the Candida albicans the epidemiology of Candida is shifting. Candida albicans used to represent the vast majority of cases. Now Candida species are superseding albicans as the most important cause of Candida infection, and they are more resilient and resistant to treatment. So if you have a superficial disease, you can use topical. If you have extensive cutaneous, you can use oral. Oral candida, you can use topical, oral, or even intravenous. It depends upon the host condition. Candidemia plus invasive disease, you have to use a prolonged course of IV anti-candidal agent, combination treatment, mainly in CNS infection and in endocarditis caused by candida. And if you have an abscess, then the treatment is drainage, mainly percutaneous, but sometimes can be surgical. And in febrile neutropenia, anybody who remains to be febrile neutropenic despite antibiotic use for 5 to 7 days may deserve treatment for candida. I will move quickly now to endemic dimorphic fungi. They are extremely rare in this part of the world. We've never seen them in Lebanon except in some patients who came from highly endemic area. For example, they are not present in Lebanon, in Syria, and Palestine, but they may be present in Africa, they may be present in Latin America and the United States. So their importance is that they are usually frequently asked about in STEP exams. So this is why you should be aware of them. The phylum is Ascomycetes, and we have main four genera: Histoplasma, Blastomycetes, and Coccidioides and Paracoccidioides. We have two other lesser important genera, the Thalaromyces and the Sporotrix schenki. Hundreds of thousands are annually infected by the main four genera, and the clinical cases range from 5 to 30%, and in some outbreaks up to 50%. They are endemic. This is why they are endemic, because they are present in certain geographic areas or part of the globe and not in others, but they can sometimes come in epidemics. Immunocompromised individuals will have a more apparent clinical disease. The endemic or dimorphic fungi, the sequence analysis and phylogenetics show that we have four major genera: the Histoplasma capsulatum, Blastomyces dermatitidis, and the Blastomyces gierrichsili, Coccidioides immitis, and Coccidioides pusadesli, and Paracoccidioides brasiliensis, and Paracoccidioides lutezi. The dimorphism and endemicity, the hallmark of the dimorphic fungal pathogen is their dual yet distinct life cycle, which means that if you see them in nature, they are usually present in the filamentous form, in the hyphal form, and if you see them, if you detect them in a human body, then they appear in the yeast form. So this is the word dimorphic here. They can be filamentous in nature, and they can be yeast-like in vivo, or spherules, like in the case of Coccidioides. They are different than Candida, because Candida can exhibit the yeast and the hyphal morphology in the same human tissue, where the dimorphic fungi, they can only exhibit yeast in human tissue. They don't exhibit the hyphal forms. They only show them in nature. Temperature appears to be of central factor that determine the lifestyle or form of the dimorphic fungi. Exposure to mammalian body temperature, our body temperature is somewhere around 37 degrees, trigger adoption of the pathogenic mode, which means that they live in nature in the filamentous form. When they go inside our body and they reach in, and where the body temperature is 37, they will probably be transferred into the yeast, and in the case of Coccidioides, to spherules. Becoming yeast or spherule will not be efficiently eliminated by immune cell, so they are likely to stay there, produce either a chronic infection. Sometimes you may clear infection, but many times the infection remains there uncleared and latent. Preventing transition into yeast through pharmacological or genetic intervention render dimorphic fungi avirulent, indicating the necessity of the dimorphic transition for the pathogenesis. This is what I'm talking about. You have the blastomyces. In vitro, they look like typical molds, but in vivo, at 37 temperature, they look like classical yeast. The coccidioides, also in vitro at temperature 25 degrees. It's a mold-like structure with septation. If you look at it in vivo, it's a spherule with multiple small rounded cells inside. Histoplasma usually looks like a mild form in vivo, while it's typical yeast in vitro, while it's typical yeast in vivo. Paracoccidioides also looks like a mold, and in vivo it is a yeast with budding daughter cells, as you can see. Sporotrix is the same here. So life cycle is not dependent on infecting mammals, because we know that these forms can live alone in nature, although be it in the filamentous form, and when they infect us accidentally. Because of our body temperature, they will be transformed into their yeast form. So the transition to the yeast spherule form, these fungi express efficient mechanism that enable survival and proliferation within the secondary environment. So they adapt to a new environment. They were adapting to an environment present in nature, temperature is 25 or less, and then they start adapting to another environment. The endemic dimorphic fungi epidemiology, they are endemic because they are present in particular geographic region rather than being found in the environment like the rest of the filamentous fungi. Endemic areas have been largely defined by a clinical case prevalence, isolation from soil, and skill reactivity test. Moist environments with decaying organic material will favor histoplasma and blastomycetes, while arid environment will favor the coccidioides. This is probably where they are present in which part of the world. I'm not going to ask you about them. However, because of your steps and because the fact that in step exam they like to ask you about part of America where these fungi are present. So this is for you later to look at when you have time to study for yourself. The pathogenesis starts with inhalation of the conidia, and the small size facilitate aerosolation upon environmental disturbance. So this is why whenever we see wind, whenever we see any environmental disturbance, we may associate it with an increased risk of infection with these fungi. And they go into the alveoli once inhaled. Occupational and recreational activity contribute to soil environment disruption are primary risk factors. Most outbreaks can be traced back to specific events that led to conidia release from soil. Within the lung, conidia transition into pathogenic phase cell which survive innate immune defenses, so they become now what we call the yeast form, we know them. So they are yeast inside the alveolar macrophages, while the coccidioides in the inhaled arthrochonidia becomes spherules that are exclusively extracellular. So if you get in the exam a question whether this is what you call yeast inside the alveolar macrophages or intracellular yeast, then this is probably going to be blastomycetes or histoplasma. However, if it is going to be spherule extracellular rounded shaped cells, then this is coccidioides. The pathogenesis depend upon and the disease spectrum depends upon whether the infected person is immune competent or suppressed. In advanced HIV patients or those who have anti-tumor necrosis factor treatment or a transplant patient, disseminated severe form may occur. Elimination of symptoms means either you're going to have a clearance of the virus or you're going to have a latency there of the bacteria fungus or you're going to have a latency there. The pulmonary disease in an immunocompetent patient is usually mild, mostly subclinical, and probably most of the time undiagnosed. However, in immunosuppressed or individuals or when you inhale large inoculum, like when you have major environmental disturbances, there will be severe form and disseminated, and you can have definitely extrapyramidal, extrapulmonary